Tonight, Dr. Marcella Finnerty. Welcome, Dr. Marcella. So just want to introduce, she holds a doctorate. She is the president of and director of IICP College, and she holds a doctorate in psychotherapy from Middlesex University. And she is here as a co-author for the journal's titling Pluralism in Psychotherapy. So we hope to grab a lot of wisdom from you, ma'am, and hope to have a framework where we can help therapists move beyond the typical dogmatic, single-minded approaches towards more collaborative and client-centered practice. I leave the floor to you to enlighten us with your wisdom, and welcome you once again. Thank you so much.
Thank you, Shantini. You're very kind, and I hope my accent, people can understand me, because I know I speak very quickly at times. So call me back at any time if you can't understand what I've said, or if there's something very pressing you want to ask. But I appreciate people coming out at 8 p.m. at night, even to their computers after being probably at their computers all week. So I hope I will contribute something to your knowledge and wisdom, but to your curiosity. That's the most important piece. I think when you're a therapist, it doesn't matter what home you operate from, what your home therapy is. Curiosity is the foundation of all knowledge. And so I hope this will help fill that curiosity. So I'm going to share a screen, if that works. And great if it does. If it doesn't, we'll find something else. I think it's sharing away there, is it?
Yes, it's visible, clear.
Perfect. So as I say, I wanted to welcome everybody, and I want to speak a little about pluralism in psychotherapy and what it means, the experiences, the perspectives and opportunities within pluralism. One size doesn't fit all. I discovered that when I went out into the big bad world of therapy and actually seeing clients. My home therapy is it's a CBT model, choice theory. I think Dr. John Crimmins has spoken to people about that particular type. So that is my home model modality. However, I found that it didn't suit every client every step of the way. So that encouraged me to be curious and learn some other theories and therapies. But I would say that acronym of CARE, I'll go back to it, CARE, collaborate with the client, adapt based on feedback from the client, review the situation, all within an ethical perspective of practicing within your level of competence, having maybe peer friends, colleagues who would help discuss cases and clients, a care team, and supervision for sure. So this is a famous quote from Carl Jung. I don't know if you're familiar with it. It's famous in Europe. He says, learn your theories as well as you can, but put them aside when you touch the miracle of the living soul. So what he's saying there is, do learn your theories, know your theories, but when you come to make interventions, remember it's another human being, and we need to tread softly because we tread on their dreams. And then Abraham Maslow, I'm fairly sure, are you familiar with this one? He said, I suppose it is tempting if the only tool you have is a hammer, you will treat every problem as if it were a nail. And that's what Shantini was saying there about one model. And you can have a pluralistic perspective, even if you operate from one model, because pluralism at its core is a philosophy that there is no one truth. There is no one right way all the time for every situation. So most people tend to have that pluralistic perspective. So as I say, begin with curiosity, know your theories, but live practice is different, as happened to me. And And pluralism can turn that clinical curiosity into a disciplined process. Different clients may need different approaches at different times. So pluralism, it's flexible, but it's not vague. And as I say, don't mind that that's my air conditioning. I have a door open. We don't have air conditioning when we're having a heat wave. So I have a door open and it's blowing my hair every now and then. So forgive me. So yeah, pluralism asks, what does this client want, or what does this client need? What is the task we need to set for the client? What method might fit, and how will we review whether it is helping? So client preferences and lived experience, that is what makes pluralistic psychotherapy slightly different to other therapies. It's not random. It's thought through. The client is an active participant in the process. So while we look at the client as the expert in their lives, you are the expert in the therapies, the theories, and in helping meet and greet the client where they're at, so that in hearing them and listening to them, you can consult, have supervision, be curious about different ways to do things. I'll mention a case study in a moment, which may give you a clearer picture of that. Yes, so your clinical judgment is most important. That can never be taken by the client. We can't give that responsibility to a client. We can't just say, oh, I'll sit back and let the client, who's the expert in their lives, lead the way. No. We need to engage the client. We need to listen to the client. We need to bear in mind what's worked for the client previously, what we think might work. We need to talk to them about it. We need to speak with them about it. But we can't just hand over our job to the client. Unfortunately, we have to do the work. So it's not, let me see, it's not, as I said, random or eclecticism, anything goes. It's not anti-evidence, quite the opposite. There's a huge amount of research going into it at the moment. It's not anti-diagnosis or anti-theory, completely not. It's not about practicing outside your area and your level of competence. As I say, it's not the therapist becoming passive, and it's not asking the client to take responsibility alone, but it is encouraging the client to take responsibility. I don't think I've ever had a session or a client that I haven't used some of my CBT, my Glasserian psychology, the self-evaluation questions, and to encourage the client to take responsibility, because oftentimes that's what has them in the fix they're in. So client preferences matter, but ethics gives us a boundary about what we can do and what we might need to bring to consultation and supervision. They're just all the different approaches, the eclectic, which, you select techniques. So that can become a little bit of a this and that and the other thing and nothing at the end of it all. Integrative, which was my own way of being with clients until I did some research and discovered actually it was pluralistic. But anyway, integrative combines theories or methods into a coherent approach. The integrative model I wrote up for our college was Rogerian, client-centered. It was Glasserian, which is CBT and choice-centered, and then multicultural counselling and therapy to bring in that piece around cultural resources and the differences in cultures. Then there's a assimilative integration or assimilative approaches which highlight, they use a home model and carefully borrow from others to try and assimilate into one. That's not pluralism, because the therapist is still the expert all the way. The client is not being involved in their therapy, in checking out what's working, etc. Then the common factors, which I think many of you will know about, which shows that the alliance, the therapeutic alliance, is one of the most important factors. I don't think anybody is going to question that, and that's certainly very important in a pluralistic approach. And there is a credible rationale for it, but it's still not pluralism. Pluralism is about that collaboration with the client, collaboratively deciding goals, tasks, methods, and review with the client. So how do you do that? That's the piece. So I have there the care, the collaborate, we work with the client, not on the client. And that's a big difference, because that also takes, I think, a huge weight off the therapist's shoulders. It places a responsibility in one way, but it takes a weight off the shoulders of the therapist, because your job is to find ways to collaborate with the client, and then fit your method, your way in to adapt to the client's, what works with the client. And clients have often been to therapy before. They've Googled things. So they come to you with ideas. They don't come as the tabula rasa, which we often say in psychology is where, is the way to come to therapy, but they don't. They come with their life's experiences, with their ideas, with their knowledge, oftentimes with a fix me quickly perspective, but we need to stand back and resist that. And then we need to ask, review, is this working for you? What is it about that works? What is it about this that isn't working? And then we also use evidence. We don't operate outside our own area of expertise and competence. We get supervision, we consult. That's very important. Let me see. Yes. This is the evidence base for pluralism. So it is research informed, not research dictated. I would say it's a very, it's a theory that's overtaking lots of other ways of doing.
I'm sorry to disturb you.
Yes, no.
No, it is, your audio went on, your audio was muted. Can you repeat the last?
Okay. I'm saying there's evidence, lots of evidence and research around pluralism, because those who developed it are researchers at heart. They're psychologists and psychotherapists. There's two in particular, Professor John MacLeod in Abertay in Scotland, and Professor Mick Cooper. He's in Roehampton University in the United Kingdom. It would have started with them and Professor Emmy van Derzen over 20 years ago. And they are all research. I was going to say, I better not say, just say that they are interested in research. Research is evidence-based, is what they want to work from. Both Professor MacLeod and Professor Cooper have written books on research, how to research, what to research. I had Professor Cooper as my external Viva consultant for my doctorate. So yeah, so research is important to them. Evidence base is important to them. Hence, with the more than 1,000 theories and therapies there are out there, they said, stop. We need to be able to help people to practice, not give them more and more information about yet another therapy, yet another theory. We need to help people to work on what's there already. Let me see. So the better question to ask is not which therapy is best, but what therapy is most likely to help this client with this particular difficulty in this context at this point in time. And the only way we find that out is by checking in with the client, or it gives us a little hint. So we use research evidence in conversation with the client around their preferences. We make the clinical judgment, and we use their cultural resources. Some cultural resources can be people like dancing, they like singing. It can be, it can mean literally different cultures, like from Ireland and India, or it can be within that culture what people find helpful to them. So now, my home model is Glasserian choice theory and CBT. So that's a strong framework for needs, choice, agency, responsibility, relationships. But it's my base, and that's the piece that we have to remember, is not to make it a prison for our clients. So my research was, how do integrative psychotherapists integrate? That was my, oh God, I lived with that for years. But what I discovered was therapists tend to have a preferred model, and I'd be very interested to hear what your models are and what your preferred model is. What I discovered was they also, while they had a home model, and oftentimes it was CBT or person-centered or psychodynamic, but all of them checked in with the clients to see how things were working and what suited them, and they adjusted their theory, their therapy and interventions based on the client's information. So that's just the practical pathway. What does the client want? That's our goal, our task. What needs to happen? The method, what intervention, conversation or resource fits this client, and how do we know if it's working? So just to give you a couple of case studies, I had somebody, this is all anonymized, so I'm not even saying it's my client in this, but the client who presented with depression, anxiety, low self-esteem, very poor self-image, difficulty with relationships, not an uncommon set of conditions with the client. But I note, or I should say, the therapist noticed a shift was needed, and from assuming that what helped the client to explicitly asking. So I was using my self-evaluation questions. Is it working for you that you are, not turning up to work? Is it helpful that you don't speak to your girlfriend and that you lock yourself away? Is this helpful? Well, the answers were very clear. No, it's not helping, etc., etc. But I needed to dig deeper, because he was giving me the answers, or he was giving the therapist the answers, but I moved too quickly into that self-evaluation, that framework. So I stepped back and I said, right, I need to look at this again. So I just listened to him. I just listened. And then I discovered all these other things, that there were layers, as there always are with clients. There were layers of under the anxiety, low self-esteem. He was socially withdrawing. His family of origin, his parents, his siblings, he wasn't having anything to do with them. He had a girlfriend who he lost because he wasn't answering calls or spending time with her. But it was deep depression, deep anxiety. So I just, the person-centered approach, I listened to him. We did some mindfulness work. I don't know if you do that, relaxation, exercises. I did a genogram, which is the family, you know, looking at his family and where some of this might have come from. I also did a pluralistic timeline, and it's a very simple piece, and lots of therapies do it, where you start with today and you look up to the future, just draw a line on a page and then go back. So we did the genogram going back. I did some strengths work with them. He actually loved art. CBT was useful. And yeah, then he went to the real world sport. He loved sport, but just didn't stay with his teammates, etc. So little by little, he got back into sport. Toastmasters here is a place where people can go to if they want to challenge themselves on public speaking, but it's done in a very safe way. So there was a couple of ways I worked with that particular client, and so it was like moving from assumption. So I didn't go straight into the Glasserian psychology, the choice theory, the CBT. Well, I did, but it didn't work. So when I backtracked into client-centered and checked in with the client, that his expertise helped me bring what I needed to bring to that session, or those sessions, to help him change. Now, this was over 2 years, but it was somebody who was heading on a very downward spiral for quite a good part of his life. And yeah, it was a success story over time. It did take time. So pluralism, I'm saying there's not many methods. It's thoughtful matching. Methods are chosen, reviewed, and adapted, and the client is an active partner. Now, I'm seeing the time flying by. I have another case which I would be very, very quick on. I think I should explain this client had great difficulties as usual: anxiety, disability, relationship, sexual difficulties, loss, grief, painful history. So again, the early work was, you know, material each week, but nothing was really working with them. Again, a timeline, conceptualizing his case with him. So asking him to participate in forming the case conceptualization, created a shared map of past trauma, a very traumatic past, and great, you know, his disability, relationships, strength, goals. We worked on lots of things, but we got there. So I'm going to just hop to the end. Sorry, I'll send these. These slides can be sent to people if they want. That's just a basic pluralistic timeline. So you go the earlier content, you know, relationships, culture, experience, their strengths from many years ago and into the current day, significant trauma or losses in their lives, their present situation, and where do they want to go? So now I'm going to hop to the end and say care, collaborate, adapt, review, and ethics. So that's, if there's anything to take away, your client is the expert in their lives. You're the expert in the clinical application of whatever you think will help the client, but you can only find that out by talking to the client. So know your model well. Don't make the client live inside it. Don't make it a prison. That's me done, finally. And thank you for listening. That was, as usual, longer than anticipated.
Okay, thank you, Marcella ma'am. Actually, I think there may be many questions out there. If anyone have questions, please type down in the chat box. And there is one question already there. How to select the therapy? How we decide the therapy? The main challenge is there, and we you said earlier about collaboratively we decide the therapy, and the how to decide that area is challenging for many of them. Any more suggestions from your side?
I'm sorry, I didn't quite catch that because there's an echo on the line. So forgive me, Faisal, I didn't quite catch that. I'm looking at some of the queries in the chat, and I'm
If
wondering,
Tusum,
so
yeah,
sorry, go on.
yes. If Tusum has asked a question, so if I am getting it correct in pluralism, do we choose along with clients what therapies to put it? I think if Tusum, you're here online as well. If you want to ask, you can ask. You can unmute yourself and ask.
Yeah.
Hello, Dr. Marcella.
Hello, how are you? I see your question. Yeah,
Yeah,
and
Ibtisam.
Ibtisam. Nice.
Ibtisam. It was a lovely presentation and it's quite new to me. I mean, the terminologies are quite new as I'm more familiar with eclectic approach and how we use integrative psychology. So this term was itself new. So it's in the beginning, I was thinking, if I was taking it correctly from you, that here in pluralism, we decide along with the client what kind of therapies to move forward with. Yeah. And in
Yes,
eclectic, we choose what therapies to put in without really asking the client. Is that the main difference?
that is a main difference, yes. Also, the act of trying to collaborate with the client, it's not that the client knows that is a therapist, although some clients are, but it's a question of you asking them, what's worked for you in your life? Not so much what therapy will I do with you. It's finding out all the information about the client that you can put to use in your therapeutic session with them. Like I've had the clients who enjoy art, or if adults, you think, oh, art therapy isn't for adults, it's for younger people. No, it's not. It's for anyone who finds that way to communicate. So pluralism is about communication, and it's about communicating at a level where you are the expert in the clinical practice. So you may need to get help, assistance to up your level of competence, or even within your level of competence, your supervision, consultation. So there's an ethical piece to it. But yes, what you're saying, boiled down to it, the client is the expert in their life. You check with them where they're at, what worked, what hasn't worked, give them their space. And then you come in, and so then it's up to you to go away and think. You spend your life researching, then you become you become an expert in many ways to do things.
We
Because
kind of become like an all-rounder.
but I think psychotherapists in particular, I think lots of professions are, but psychotherapists in particular never stop learning, never stop being curious, never stop trying to find ways of different ways of doing things. And yeah, but pluralism for me gives me that, sense that I'm not hammering that nail. I have a box of tools. I don't just have a hammer. I actually have, if that isn't working, I can try something else with them, but with their permission and in an open, collaborative fashion, which is the different is quite difficult, and particularly with clients who have serious mental health issues.
Yeah.
So, but yes, you have
Thank you
it.
for clarifying that. I have one more small doubt. Like you mentioned, there are a lot of clients who come to us with already, Googling, and they kind of know a lot of things. They've taken all the knowledge and come to us. And let's say somebody comes who has absolutely no idea about any therapy approach. So I think how I've understood from you is that we kind of start with like an eclectic approach, but then we communicate with the client. We tell them that because as they do not know and they cannot really tell us which one to go forward with, we start with our expertise. We try to join which therapies would really work with them, and then maybe let them know that these are the ones that I'm trying and how do you really feel about it. So which one is really working for you? That's how the roadmap looks like.
Yeah, absolutely. But you don't have to explain to your client, I'm using psychodynamic psychotherapy with you. You can say, let's talk about what happened in your childhood. And that timeline I mentioned is very good for getting that information, because at the end of the day, it really moves people up to the top end of the timeline. Okay, they've talked about their childhood, we've teased things out, and they tell you things they haven't told anyone else. People they have shame, they have guilt, they have anger, they have all sorts of emotions, and they haven't expressed them to anyone the way they express them to you. So it's a very privileged position to be in, and therefore we want to collaborate with our clients, but they're not experts in psychotherapy, they're experts in their lives. You're the boss when it comes to, well, it's a collaborative piece, but you will know at
To
least
kind of bring in.
to bring in. Exactly.
Thank you so
Thank
much,
you.
Dr.
Thank you
Marcella.
so much. And thank you for your patience to everybody. If you want to send questions to me, I can answer them in email. We can leave my email if you want. Or if anybody wants it, because I notice it's 1 minute past your, oh no, I tell a lie. What time is it with you?
Yeah, we
We
still,
have, I think we
No,
have
it's
some more time.
8:30.
Yeah.
We still got time.
Yeah.
I'm on the hour. That's great. Sit back. I can relax. Ask any question you like.
We have one more question. So
I rushed because I thought it was an hour, but it's 30 minutes. We're 4 hours, 30 minutes behind you. So I lost 30 minutes in my calculation, but that's not unusual for me. So ask away.
yes, we have another question. Meghna, if you want to unmute yourself and you can ask as well. I see that you have a question here. Or somebody was asking.
Yeah, hi ma'am. Hi, how are you?
How are you?
Actually, firstly, I love the presentation that you gave. It is a very new term for me as well. I knew the elective approach, but not this one. The question I had was that, let's say, like, we choose a therapy for them, let's say CBT and art therapy, we mix it together. And then as we're going with the therapy, we see that maybe it's not helping them. So is it okay if we change it in between? Like, won't the client feel a bit like, okay, what just happened? I mean, obviously they won't know, but then we would know that we have changed it. So won't that?
Yeah, no, it's a very, very, very astute, very intelligent, good question. This is the point of collaboration. You'll have said to your client, I'm going to try a particular approach with it. They don't need to know what it is, but I'm going to talk about your childhood, or I'm going to talk about, I'm going to ask you some questions. Now, we know they're Socratic questions or self-evaluation questions, but we don't need to tell them. We can just do that. And then when it comes to a certain point and you have a sense it's not working, you just say to your client, is this working for you, or should we try something else? So that helps you step very nicely back. Because you don't need to have the answers. That's pressure we can put on ourselves. We hardly have the answers to our own lives. We certainly don't have the answers to anybody else's life, but our job is to help guide them. And that we can do without getting too technical with them, because people don't really want that. As I say, you can say, look, we're going to have a look at your childhood, or we're going to I'm going to ask you some questions. And then if you sense a resistance, you can say, is this working for you? And it might be. And if they say yes, you believe them, believe whatever they say. And if they say no, then say, okay, will we try something else? Tell me something that has worked for you in the past, in your relationships outside of therapy. I mean, we don't expect everyone to have been in therapy several times. This may be their first time. And as I say, it's when they come to reveal the deepest parts of themselves, that's where you're really grateful that you will have collaborated with your client, because there's a lot of guilt, shame, and anger and sadness We don't take that on. We can empathize for sure, but
Yeah.
we can't
Yeah.
take that on. Okay, they're
Yeah.
the experts. But
Yeah, they're
yeah,
the experts. Yeah.
yeah, good
And
questions. Really good questions.
thank you. Just one more. I think this might
Sure.
be a silly one, but then you did mention that, there will be some clients who, they've done their research and they come for the therapy. So what if I'm doing the therapy, let's say CBT, and they figure it out, oh, she's doing this with me. And if they ask me that, are you doing this with me? And then what am I supposed to do in that situation?
Okay, what I would usually do is say to people, my home is Glasserian psychology, choice theory, and CBT. You might know what that is, but this is where I will be working from. If you want me to explain it to you, I will. So I try and involve them as
Oh,
much as
okay.
possible. And
Okay.
believe you me, nearly every client will have heard, well, that's not true, that isn't true, but a lot of my clients will know CBT and they'll say, that works really quickly, 6 weeks
Yeah.
and I'll be finished and I'll be free and I'll be fixed. And I
Yeah.
think, well, we won't put a timeline on it in that way. Certainly it would be good if we could do that, but generally at 6 weeks, you're only getting into the real work of therapy
Exactly.
with
Yeah.
them. Yeah, but just it's about you are the clinical expert, but you are also sharing the client's expertise, which is in their own lives. And that's there. So you can hear from them their story, which will help you help them to move on in their lives.
Yeah.
And we do that. The trust is built. We don't tell them every little, it's not a
Detail.
psychology lesson we're giving them.
Yeah.
It's
Exactly.
therapy, but we do want to share with them, okay, what's going on in your life? What do you like? What their likes, dislikes, the simplest of things. But we try and get as much information as we can before we go into the therapizing, because that's when you eventually figure out either they don't come back or they come back and are very honest and say it's not working.
Yeah.
And then you
Yeah.
say, oh, okay, right. And where can we start? And the therapists that I interviewed for my own research, all of them, without question, had tried the piece where they thought that they were the expert. That was their job. And it
Mhm.
is your job, but it's not, you
Yeah.
can't do it until you know your client.
Exactly.
So you know your client as well as your theories.
Yeah.
That's the
Very well
secret.
said, actually. I like that perspective. Nice. Thank you. Thank
Thank
you so
you
much.
for your questions. Thank you.
Thank you. Thank you.
Well done. Oh, look at beautiful photo there.
Oh, thank you,
Ola,
ma'am.
Yeah,
any more questions? Feel free to ask.
please feel free to ask. Oh, there's somebody here.
No, that's same.
Oh,
Meghna's
that's
question.
yourself. Yeah. You've asked that woman, yeah.
Yeah.
Anybody else?
Safa ma'am, I see you're online. If you have any questions, please shoot.
I, Dr. Marcella, thank you. I was just wondering about when you mentioned using cultural resources of the client. If you could say a little bit more. You gave dancing as an example. I was just trying to think how to. Yeah.
Cultural resources are anything that the client has in their lives that is supportive to them in some way. It can be literally family. It can be knitting, sewing, football, public speaking, anything in their lives that are part of their culture. For instance, in Ireland, we have there's an urban-rural divide. So I'm in the urban area. I'm from the rural area, so I know all about well, I won't say I know all about, but I have lived in both settings, and I find the cultural resources from the rural setting very different to the cultural resources in an urban setting. In a rural setting, we would value far more small groups meeting for music, just talking, going out for a walk or a climb. In an urban setting, people are more likely to go out to dinner, to go out to a restaurant, and they're not so keen to have people in. Although having said that, I do both. I have people in, my cultural resources, my family, friends, have them in, talk, enjoy, whatever. But you find when people are depressed or anxious or come to you with these issues, they'll have stopped doing something they really enjoy.
Right.
And that's a cultural resource. It can be anything.
How would you integrate that into therapy? Like, for example,
that's somewhere
how would
where
you say it to a client?
Just by that timeline and starting with the present where they are now and going back and what they used to do, what they enjoyed doing. They will also tell you all the things, the trauma in their lives. Okay, so that was a very traumatic time for you. How did you manage that? They will tell you. There will always, I haven't yet to meet a client who didn't have some resource that they could call upon, but generally they'd given up on it. They'd stopped doing something that, really helped them, help them manage their issues in that time, get away from thinking in their heads and do something else, be with people. As I said, that first case study I mentioned, that client was, he had stopped meeting his family, he'd stopped playing sports, he had stopped seeing his girlfriend, he had stopped, he enjoyed public speaking and events, he had stopped all of that. Depression, anxiety took over. So little by little, his cultural resources, the first thing was sport. That was the first thing. And it was, I don't know if you have it in India, we have 5-a-side football. So there's 5 on a team. And he managed to get back into this 5-a-side football. That saved him, and got him onto Toastmasters, public speaking, everything. It was a slow build, but that was a cultural resource, sport, and even watching sport with people. So cultural resources are particular to a group of people. I don't know, if you were to give me some examples of a cultural resource for you, what do you do when you're chilling out, when you maybe on a Saturday night when you're not in front of your computer? What else might you be doing?
I mean, that's the thing I was thinking about, because generally it's going to restaurants or meeting people or having people coming in. It's a very close-knit community in this way.
Yeah.
But I was thinking about patients who, especially young patients, if they've been detached from people for a long time.
Yes. Yeah.
And I don't really hear them say anything in terms of what they like to do. That's why I was asking this question. How to talk to them about it and how to sort of help them.
I don't know. Sometimes young people, music can be a way to get through to young people. Are there traditions, family traditions? I don't just mean cultural traditions in the wider sense, but in the narrow sense of cultural traditions within the family. Are there, is there anything that they can cling on to that will help them reconnect with reality, with day-to-day living, anything? And I don't know, is it popular, or is it seen as ethical, what we call in Europe walk and talk therapy? So it's literally where you go. I know when I was training, I was at a therapeutic day yesterday, and we were just talking. They were saying, "Oh, walk and talk therapy is so good. It's so this." I remember when I trained, if you went outside your office with a client, that was seen to be a breach of your code of ethics. And now it's being promoted as a way of conducting therapy, particularly with young people and people who that eye contact is almost felt as an intense burning into their soul that they don't want. So there's lots of ways, but I think the cultural resources is a safer way to do it. I'm not promoting
Right.
walk and talk therapy, but I'm not coming down heavy on it either. It seems to work for people. Once it's ethical, above board, people are supervised. I have no problem, and they're operating within their level of competence. But I hope that answers your question.
Yes, it does. Thank you. Thank you very much.
Thank you. Oh, I
Thank
see
you,
a question.
Superman.
Do I see a question there? Did I see a question?
Walk and talk therapy on a cup of black coffee is a novel idea. Dr. Faruqi, you want to ask? You please feel free to ask. You can interact.
No, madam, nothing is there much because already it has been that net has been a vast area of selecting a therapy for a particular patient, a particular client. That depends, madam, as told, depends on the nature of the patient and its background, is past time life trauma. So many factors has to be considered in order to fix a particular therapy that is most suited for that client sitting in front of us.
That's exactly it. Yeah.
That is the actual what is that? That is what actually we had to understand during this particular sessions of CBT and selecting the particular therapy. So we may have to have some time, maybe 1 or 2 sessions or 3 sessions may be needed to finally conclude which therapy will be most suitable for this particular time sitting in front of us. So that there are many dynamics and there are many factors has to be assessed, and finally we have to decide which therapy will be most suitable for them, so that we will have a open discussion with that particular client, and we have to check it out whether it works or not.
That's so true. That is so true. And actually, you may have a different therapy at different times, because I heard someone on a webinar say they were talking about two-chair therapy. So whoever that, it must have been somebody who was Gestalt, trained in Gestalt therapy, because that's a two-chair method is Gestalt. So there might come a time when you want to practice, when you need initially to practice Rogerian, Carl Rogers, person-centered. But then it may come that you want, they need to deal with some past traumas, and two-chair therapy is the way forward, or art is the way forward, or as you said, a cup of coffee on a walk and talk. That's I know people who do that, and it is, once they have supervision, it is now within our codes of ethics in Europe, not just in Ireland, but in Europe. And I think in the United States also, it's this narrow version of therapy is widening into a more pluralistic view of the client, of the therapy, and of what constitutes a therapeutic environment. But the therapist, psychotherapist, is always the one who holds the clinical responsibility, no matter what. So as you say, you need to know your client and to know what therapy might work for that problem at that time. And sometimes going back will work. But then as they go through therapy, it may be time to hop into CBT or Glasserian or choice theory and get some questions asked around, is what you're doing helping you get what you want? What do you want? So at different times in the therapy, you may choose different approaches depending on what's needed.
Yes.
So I go to you
It's a very good.
for that walk and talk therapy because there's coffee involved as well. I think that's a very healthy addition.
Yeah. We as a therapist, as a client, will have a lot of freedom to share rather than concluding in a consulting room. No, you are exposing to an open area. The nature will have a added-on effect on us, both on therapist and a client. I hope so.
Absolutely. Yeah. Well said. Well said. Thank you.
Thank you, ma'am. Thank you. Thank you for the nice and fresh presentation.
Thank you. Everybody has been so extremely involved and intelligent and far-seeing questions. Yeah, we don't get asked those questions this side of the water, which is great to, it's really good. It's making me think. Yeah, so it's good to hear them.
Dr. Cummins has tuned like all of us, the first batch of Mind Algo, all the candidates. He has been tuning us like that mode. Our inhibition, a lot of inhibition has been overtaken, and he has immensely helped to control our own limitations, you know.
Yes.
So that is the reason we are all performing well, hopefully.
Yeah. Yeah. So thank you to Mind Algo and everyone for that. Yeah.
Do we have any more questions?
Any questions from anyone? Otherwise, we can conclude. And yeah.
I think Anasuya ma'am have one question. Do you have,
Okay.
ma'am?
Hello, ma'am, doctor. Actually, I don't have any question, but I just want to congratulate the wonderful session. In fact, whatever doubts I had earlier, you clarified everything, and so that, yeah. And of course, everybody has questioned so beautifully. But still, I have a walk and talk therapy that I have adopted as a school counselor with my students, because sitting in one like a jail kind of a room, sometimes they feel suffocated. So then I just tell them, come out, let's go for a walk. And then, going around the big ground, around the football ground, and then talking to them. That's really worked well with them.
Yeah.
And presently, if I have to, I have one question to ask. I have a counselee who is just overcome from her cancer treatment. She underwent a surgery. She's with me for the past 1 year, almost a year. She came because she had anxiety to go through the surgery process. And so from then on, it started. So I was just helping her with all the grounding techniques and everything with her. And then very successfully, very confidently, she went for the operation, and it was successful, and she's doing very well. So initially she was taking sessions almost every day, even from the hospital. She wanted to talk to me, and then she was talking to me. So now, weekly once, she wants to compulsorily talk to me. And sometimes it'll be just a talk therapy. Sometimes I'll be adopting all the, some relaxation exercises, open share, and a lot of traumatic experiences she would share with me. And now I'm focusing only on CBT now. And that's really working well with her, and she's really liking it. And I thought, okay, so in between the CBT, I know I was adopting even the relaxation exercises also, and I was wondering, is it okay? I'm just going into this CBT, and in between I'm coming to this. I was questioning myself, is it okay? So now I got the answer, yes. So whatever suits at that particular moment with them, and if they are comfortable and that works very well with them, yes, I can proceed with that. So I got that.
Yeah, I hear from you. First of all, congratulations. I think you're the first pluralistic therapist over in India. You're certainly the first walk and talk therapist.
No, no.
With young people, it works very well because they don't want to look you in the eye. They don't want to be stared at. So to me, you sound like an intuitive person, and like you have a psychotherapeutic intelligence that says to you, there's no point in sitting in this office with this young person. We need to get out. So that works. You used Rogerian therapy with your client when that was required. Now you're using CBT because that's what's required. So that is pluralism. That's what I'm saying. It's what works for this client at this time. So in 3 weeks' time, something else might be needed. But a month ago, client-centered therapy was needed. With your student, walk and talk therapy was needed. That's pluralism. So thank you. That is a wonderful way to bring the webinar to closure. Thank you so much and for your kind comments, and well done. Please keep in touch.
Definitely. Thank you so much.
Thank you.
I don't know if we have time. We just have a small question here. I'm not sure if it's to be. Can we add forest therapy as a psychotherapy?
Absolutely. I would say that it makes 1001 therapies, and that makes a smart one. But that's, yeah, go ahead.
Yeah.
And whoever is writing, make sure you write a book.
Now that we have come to the conclusion part of this session, I just want to thank you on behalf of MindAlgo and all the people who are present here. A huge thank you from the bottom of our heart for giving us such beautiful insight, for sharing deeper knowledge about pluralism and psychotherapy, keeping the goal in mind, the wellness of the client, rather than sticking on to rigid therapy modules, but the end result is that we need to focus on clients' well-being, and for that we need to adapt and change and arrive at that the reverse pattern that you showed. The goal is first, and then integrated approaches to reach to that, and that's very beautiful. That's a beautiful insight. Thank you so much, and on behalf of everyone here, we thank you. Dr. Faisal, if you want to add something, yeah. So
I'd just say one thing. Can I just say, I am so heartened. My heart is lifted by the spirit with which people have engaged with this pluralistic approach. I think psychotherapy in your country is in very safe hands. And MindAlgo is a great place to come together and consult, supervise, learn new skills, learn new ways, and gain confidence that you richly deserve, absolutely deserve. So thank you for everything and for your engagement, and to MindAlgo for their kindness in looking after me.
MindAlgo is in a mission to come out with good modules for psychotherapy. We do integrated approach is what we enhance. So we have lots of plans and missions and visions in pipeline to help the psychologists all across the world, to give very much an integrated approach where the goal is to help people, give mental health to people, craft the psychologists and people in the wellness industry. The product is there to deliver to each and every one of us.
Yes, and you have wonderful people on your webinar, your participants. That's why I say it's in safe hands with MindAlgo, but also with the people who have come on the webinar. Very, very, very experienced, and there's a humility to each person that has been on, that I've spoken with or heard from, that will serve you and your clients very well indeed. So thank you.
Thank you so much.
Thank you. We'll talk again.
Thank
you, Dr. Marcella.
Bye, everybody.
Bye.
Take care now. Bye-bye.